So we know that targeted therapies for BRAF mutant melanoma with BRAF and MEK inhibition can lead to very high response rates. Indeed, clinically, there is the expectation that virtually all patients will get some clinical benefit from that combination. However, the problem with targeted therapies with BRAF and MEK inhibition for BRAF mutant melanoma is a development of acquired resistance, which occurs in the vast majority of patients. In contrast, the immune checkpoint inhibitors have much more durable responses. However, their limitation is that only a proportion of patients respond. We also know that when a BRAF mutant patient is treated with BRAF and MEK inhibition, if you look biologically at their tumours, that there is an influx of T cell following BRAF mutational pathway inhibition, and that is associated with other favourable changes in the immune microenvironment. So the hypothesis to be tested in the IMspire 150 trial was, could one utilise that biology, inhibit BRAF and MEK inhibitors to inhibit the pathway in a way that would give very high response rates, but improve the durability of response by the addition of an anti-PD-L1 immunotherapy. So the IMspire 150 trial was a phase 3 trial, randomising over 500 patients to the triple combination of the anti-PD-L1 drug Atezolizumab combined with the BRAF inhibitor vemurafenib and the MEK inhibitor cobimetinib. And that was compared by randomisation to a placebo infusion for atezolizumab plus vemurafenib and cobimetinib. So that was the basic design. The primary endpoint of the trial was progression-free survival that was investigator assessed. But a very important secondary endpoint of the trial was overall survival. So the key finding from the IMspire 150 trial was that progression-free survival that was investigator assessed was indeed improved in the triplet arm compared to the doublet arm of vemurafenib, cobimetinib. The addition of the anti-PD-L1 drug improved progression-free survival. What was very interesting about the Kaplan-Meier curves in the trial is that in the first 6 months of therapy, there was no difference in progression-free survival between the two arms, but following that, progression-free survival benefited in a statistically significant way the triplet therapy arm. I mentioned the key secondary endpoint of overall survival, so we've only performed interim analyses for overall survival at this stage because there haven't been sufficient events, but there is, a trend already towards overall survival favouring the triplet therapy. I think what is most important to me about the trial was the initial biologic-based hypothesis that the duration of response to BRAF and MEK inhibition could be improved with the addition of the anti-PD-L1 drug, atezolizumab. And this indeed occurred with a significant improvement in duration of response for the triplet arm, a 70% improvement in the duration of response with the addition of the anti-PD-L1 drug to BRAF and MEK inhibition. And I think this is quite clinically significant to the treatment of our patients. The main conclusions from this trial is that duration of response to BRAF and MEK inhibition, which occurs in a high proportion of patients, is improved with the addition of the anti-PD-L1 drug. And very importantly is safety, because in oncology, as we combine more agents, we are finding that toxicity can be increased. But in fact, the toxicity of the triplet therapy with atezolizumab added to vemurafenib and cobimetinib was quite similar, particularly as measured by adverse event-induced discontinuation rate. So in fact, the toxicity was very acceptable, and combined with the efficacy, I think this gives us a new option moving forward for treatment of patients with advanced BRAF mutant melanoma. So the major adverse events in the trial were very much as would be expected with vemurafenib and cobimetinib monotherapy, particularly in cycle 1. There is gastrointestinal toxicities with diarrhea, nausea and vomiting. There are liver function test abnormalities. And the triple therapy arm, these toxicities were actually quite similar. What did occur at slightly increased frequency were toxicities that would be expected from inhibition of PD-L1, namely thyroid dysfunction. There was a higher rate of increase in transaminases, and there was also some fever and arthralgia, toxicities that can occur with anti-PD-L1 therapy that were seen at higher frequency. But overall, the therapy was well tolerated in the triplet therapy of the 3 agents. One of the important things coming out of this trial will be ongoing follow-up to see if indeed there is an overall survival benefit of the triple therapy of anti-PD-L1 with BRAF and MEK inhibition compared to BRAF and MEK inhibition alone. This will be very important analysis that will give us further information about this being routinely moved into clinical practice.